Welcome again. So my name is Sri Ilaprolu. I lead our solutions architecture practice at AWS. You guys have been hearing quite a bit about IoT and some of the capabilities that customers are able to derive from that technology and concept. In this session, we'll try to focus on how health, especially the public health arena, can leverage IoT and connected devices and so on. So rather than me speaking about it, I actually have a couple of customers that are going to be talking about some of the innovative stuff that they're seeing and doing in the healthcare space, leveraging connected devices, wearables, and so on. So I have a couple of customers. The first customer is going to be Gary Clifford. He's from Emory University. He'll go through and present and talk about some of the innovative stuff that they're doing in the research space. And then after that, we'll have Prad Prasoon coming from American Heart Association, and he'll talk about some of the activities that they're considering at AHA. So without any further ado, Gary.
Is the microphone on? Should be on here. Can everybody hear me okay? I'll go to the backup. Let's see. All right. So I'm going to talk about some fun stuff that we're doing in terms of using Amazon Cloud to extend our mHealth capabilities at Emory University. And in particular, I'm going to talk about the backbone that we've been building for two projects. One is with Morehouse University and Morehouse School of Medicine, and the other is with Emory University and Georgia Tech. And in particular, I'm going to talk about something called the Healthy Aging Study today, which is a project that is taking off right now. The background to this, and I'm going to be very, very quick. You don't have to read all this. The point of this is brain disease is a big problem. So if you look at some of the figures here, we have 18.8 million, 9.5% of the U.S. adult population has major depression. And in fact, actually, unipolar depressive disorder is the single largest burden of healthcare on the planet now. It's overtaken cancer, it's overtaken heart disease, and it really is the biggest concern and a growing problem for us across the world, particularly in low to middle income countries. Yet we seem wholly inequipped to deal with it and also to understand it. It also factors into many, many other diseases. So at Emory University, we started a program called the Healthy Aging Study, and our aim is to collect data on 100,000 individuals over the next decade and look at the progression of brain-related disorders, and in particular Alzheimer's. So if you want to find out some more about this project and drill down on some details, all you have to do is Google Emory's Healthy Aging Study and go to healthyaging.emory.edu and have a look around the website. And you'll see that the tagline, if you have the opportunity to change the world for the better, would you, is a bit optimistic, you would think. But I think the promise that we have with mHealth technology is going to allow us to drill down on massive populations. The point of the Healthy Aging Study, as it says, is increase our knowledge about the aging process to ensure that the future generations will enjoy a long and healthy life. So what we're going to be doing is tracking normal or supposedly normal people taken into the study at random over a period of 1 to 2 to 3 decades, if we can do that, and watch the aging process and look at early symptoms and long-term symptoms of Alzheimer's. And this is not as fanciful as you might imagine. In fact, there's some really interesting work, preliminary work that's been done out there where one of the earliest studies was on a group of nuns looking at some of their writing, and they showed that the grammatical construction that these nuns had in their early writing in their 20s was highly predictive of developing Alzheimer's later in life. So you can actually pick up these kind of early indicators of long-term downstream healthcare problems. And then the question is there something that we can change in the lifestyle or the physiology or the chemistry of the body that will allow us to mitigate the problems that we're likely to see. And if we can reduce that, then we reduce the entire burden of healthcare, as well as improve the quality of life for millions of people. So the Healthy Aging Study, in particular, is going to look at multiple different assays. What do I mean by that? Well, we're going to be looking at everything from physiological function to fluid biomarkers. We're going to be taking lumbar punctures, not of 100,000 people, because that would be too expensive, and probably we won't find 100,000 people who will let us do lumbar punctures. But we'll be doing brain imaging and multiple modalities. And the bit that I'm responsible for, the little bit over here on the left, is cognition, mood, activity, and sleep. And the way that I'm doing that is through apps on mobile phones and external sensors that we can pick up from the environment, and sucking all this information up through the Amazon Web Service architecture. So that's what I'm going to talk about today. I'm not going to talk about all the other exciting stuff over here. You can find out all about that on the website. So what am I doing in this mHealth space? Well, you've probably seen a lot of things to do with mHealth, and there's a lot of buzz around this. A lot of it's noise, a lot of it's random data coming in from consumer devices, but also a lot of it's useful information. So I play around with a whole host of different devices, and I'm lucky enough that the companies trust me to open up their back ends and let me into the raw data. So my job is to get as close access to this data as possible. So an example, if you look at the top left picture there, that's an epidermal tattoo. It's basically an ECG sensor, an electrocardiogram sensor that is on a tattoo that goes on top of the skin, and the tattoo itself has the same compliance as the human skin. So you can actually do a long-term ECG recording with pretty much no interruption to the patient's lifestyle. We're using various versions of that, and that's with a company called MC10. In the top right, you see a couple of classic consumer devices. One of them is the Jawbone, and in fact, we're using the Jawbone Up 3, and they're giving us access to all of their raw data to be able to pull people's daily activities and daily sleep structure straight into our longitudinal record. So as long as somebody's wearing these devices, and I'm wearing a few of them today, I like to compare them against each other. And it's amazing how different they can be. But my job is to analyze the data coming off these devices and normalize them so that they become meaningful, instead of just accepting the information that's being pushed to you in terms of steps and the traditional consumer information that has no healthcare validity. And then we're also looking at environmental sensors. So we ran a workshop with Amazon last week, actually, at the Exposome Center, which is a center at Emory University that looks at exposures in the environment and how that triggers changes in people's health. So we look at everything from the pollution in the atmosphere to the temperature and humidity in somebody's house, to the weather and the local weather conditions and traffic conditions. And all of this can be pulled out of external sensors that already exist. So everything from satellite mapping down to in-house sensors that cost pennies on the dollar. So where does the science come from for analyzing this kind of data? This is the only bit of real science I'm going to show you today. So this is some recordings from a cell phone from two different individuals. One person has borderline personality disorder, and one person has no medical conditions that have been diagnosed. They're essentially our healthy control. And what you can see is from top to bottom, I've plotted the person's activity. The brighter it is, the more active they are. And then from left to right, this is their activity over 48 hours from top to bottom. And from left to right, it's their daily activity over a period of several months. in spring 2014. And the key thing is, you'll note that I've plotted 48 hours, so it's called a double plot. And the reason for that is that if you look across a double plot, so it's got Monday, Tuesday, then Tuesday, Wednesday, then Wednesday, Thursday, then Thursday, Friday. The reason for that is you can see lines through these graphs very, very easily. If those lines are stable, they indicate that you've got a normal circadian rhythm. You get up and you go to sleep at roughly the same times every day. That actually turns out to be incredibly predictive of many, many health problems, from obstructive sleep apnea through to schizophrenia. Sleep is actually one of the first things that gets disturbed in any illness, particularly if it's brain-related, because often the sleep centers of the brain get disturbed. And if it's not one of the first things that gets disturbed, it's often one of the things that causes a disturbance itself. So if you have a sleep-related disorder, it can lead to other long-range healthcare issues. So looking at sleep structure is absolutely important. So we can see on somebody's daily activity, and our plan is to do this pretty much on everybody that we pull into the cohort, and track their sleep over months, years, decades, and look at the slow degeneration of the sleep structure. And it will happen. Everybody's sleep changes over the course of their life. The question is, can we see how well that sleep structure degrades? And is it degrading too fast? Is that predictive and indicative of a particular brain disease? So you can see in these two pictures that the patient on the right-hand side actually has a much more disturbed pattern. They're up and down at random intervals. And actually, if you look at a measure of randomness in these two different charts and box it up into different timescales, it turns out to be extremely predictive. We did this on schizophrenic patients as our initial data, and found that we could differentiate between schizophrenic patients and normal controls with a 90% accuracy using just the analytics of these type of data. And we published this a few times, and this led to us bootstrapping onto larger and larger trials to look at larger and larger data sets for more and more different types of diseases. Because it's not specific to schizophrenia. You have these degenerations and these patterns in lots of different types of patients. The other thing we're looking at are the contexts of what's going on in somebody's life, because it's not just the fact that your sleep's changing. Your sleep could be changing because you've flown to DC, for example, to present at an AWS conference. That absolutely destroyed my sleep this morning. I only got 4 hours. Thank you, David. But it could be many other things as well. You could have just had a new child. That certainly disturbs your sleep, especially if you're the mother. But there are natural patterns to this. And what you need to look for is context within that data stream to be able to decide whether that's normal or not. So a sudden change in sleep pattern when nothing else is changing is something that you should be worried about. But of course, if some other factors are changing simultaneously, it could be indicative of, say, a psychological trauma. So one of the examples here is we're tracking the social networking behavior of the individuals who are using the app on our phone as well. And what you see, every line here is a different person that the individual who has the app is communicating with. The size of the circle is the amount of communication they have with that person in any given day. And you can see that there are very complex patterns of social interaction between each individual and the people that they interact with. I should note that all of this is de-identified. We have no idea who they're interacting with. We just know that there are N people in their social network and that they interact with them in different bursts. So there might be somebody that they're interacting with, once a month. And if it's somebody in their 20s, it could be their parents. They're going home and doing their washing, or they're asking them for some money or something. Or if it's a daily activity, it could be your spouse or your kids. So there's a certain distinction within the pattern that allows you to try and identify the types of people that you're talking to without actually revealing any particular personal information about people. And then one of the other key factors that you have to normalize your data for are movements. So the other thing that we're collecting on the phone are movement patterns. And again, this is completely de-identified. 0 point is the point where you spend most of your time, which is probably your own home. So I'll give you an example here. This is somebody's two-dimensional activity over a 40-kilometer by 40-kilometer grid. Sorry, it's not in imperial units. This is done in Europe. So we have a grid that this person moves around, which is kind of their normal behavior. You can see there's this sort of spider web of activity, but it's very easy to decide what they're actually doing and what kind of loci they spend most of their time in. So this is all the same data, but removing all the data that isn't during the night, that isn't during the day. So just the nighttime locations, and you can see quite clearly that this person spends most of their time at this one given point, and mostly at night when they're not moving around. So that's clearly their home. Then you see that they have a secondary pattern during the weekday, so another spike in this graph, and they spend a lot of time at this other place slightly, over in the background. And that turns out to be their work, and they're moving between the work. Because if you look at just the weekdays during 9 to 5, you find that that spike is much, much larger. And then if you look at the weekend, again, they're spending a lot of time at home. They don't go to the office very much, so this isn't David's tracks. And then they have a little bit of activity outside the home as well, so probably going to the shops or something like that. And it's very important to get this kind of this location activity, because if you suddenly start having changes in your physiology and your activity, but you're not at home, then that's to be expected. One of the dangers of collecting all this kind of information is the amount of false alarms that we're going to generate from it. So collecting lots of different types of data is very important. So now you can see that I'm trying to suck up a lot of information here. This information is coming in at about 50 samples a second. So every day I'm collecting hundreds of thousands of samples on everybody on their very tiny, minute movements. So if their hand's tremoring, then I'll pick that up. If they're walking slightly funnily, then I'm going to pick that up. And I'm going to know where they are down to I deliberately make it a little coarse on the spatial grid, but we know pretty much where people are from minute to minute. So we have this app. I was going to give you a little demo, but the video's not working. But if anybody wants to have a look at it afterwards, I can run it on my laptop for you. So we have this app where we have an architecture for enrolling people through a study, and then they have they're enrolled through the study, they consent to their data being collected in a de-identified manner. The de-identified data gets pushed to Amazon, and the medical data stays within the clinical databases at this point. We may be moving to a unified system over the next few months. You just need Emory to sign a little piece of paper. And so basically, this is the workflow. We have this app. The phone connects to an API on Amazon EC3, and it's load balanced. This then communicates with Salesforce. This is a historical artifact of the fact that we have a BAA with them and a HIPAA-compliant server. So this is where the identifiable information for the patient sits. Then this says that there's valid user information. It passes this information back to Amazon. This is then validated, and an encryption key is given from Emory's data center. I know it's convoluted, isn't it? And then this certificate's returned back to Amazon and issued back to the mobile client, where it encrypts the memory on the phone so that all the data is kept secure on the phone. So we have a certificate system that validates somebody within the study and allows us to track them continually. And then the app does periodic uploads, usually about once a day, but we set it varies depending on the kind of network connectivity, from once every 3 hours to once a day. And usually at night when they're home and they plug the phone in, and then the data volume gets uploaded to Amazon. And then once it's uploaded, we trigger a bunch of scripts on AWS that does a daily digest on what's been uploaded, how much data has been uploaded, and then derives our metrics for normality. So all of the research that I was showing you earlier about the randomness of somebody's behavior. this is the exciting diagram of how all of that's happening at the back end. I'm sure most of you are not going to want this, but the key point here is that it's actually a standard setup. So we have all of the data coming in through the elastic load balancer. This distributes the load across the web servers. There's an auto-scaling group, so if we get a lot of requests, it just spins up new instances on Amazon intelligently, so we don't have to worry about load balancing for that. And the point of this is we're expecting hundreds of thousands of people to be uploading hundreds of megabytes, possibly gigabytes a day from every day from these transactions. So there's no way that I want this coming in through one data port at Emory. And also it's spatially distributed. So if you think about this, this is going to include people from all over the US and potentially all over the world. And that's a very, very important point. So it turns out that one of the advantages for us as well here is that Amazon has data centers around the world. So I can do a project in the UK, and my data is legally not allowed to leave the UK. The ethical approval, the IRB approval that I get for running that project over in Ireland, over in the UK, means that I have to keep the data there. But that's not a problem. I can keep the data over there on an Amazon server, go and process the data on there, work out what the results are of that particular study, and then still publish that without ever leaving my office in Atlanta. And that's very, very important that I can be able to spatially distribute that. There's a lot of reasons why clients don't want the data to be leaving their particular zone. And then all of the information is stored in either in a relational database, if it's abstracted information, or as URLs within that database pointing back to data on S3 buckets. So most of my data is very heavy binary data that I'm processing with scripts on the back end, either in Python or C. And all of that needs to be linked back to the abstracted data sitting on the relational databases. So that's basically the architecture. We have this tool, which is essentially, hopefully, a longitudinal tool that people will use to track their behaviors and be able to actually see their information over time and see how their sleep structure is changing and see how their activity is changing and see how their health, their general welfare is changing over life, and have that correlated back to other biometrics within their healthcare record and contribute as well to the pool of data that we're collecting for scientific discovery. So that's basically it. This is the team, or the leadership team on the bottom left. This is, I'm just a tiny bit of this. And this is led by Professor Alan Levy, and he's assembled a crack team of clinicians and data scientists. And I feel very proud to be working with these guys. So thanks again, Sri.
Can everyone hear me? Thank you. Stanley, am I on? Thank you. So good afternoon. I think it's really a big pleasure to be joining you all of here, talking about some of the exciting things happening at the American Heart Association. I must acknowledge that the last couple of days have been pretty exciting, hearing all the great conversations that our friends at Amazon have put together. I'm particularly excited to talk about some of the portions today in this meeting, because I do believe that there are people and minds in this room here who will transform the paradigm of healthcare, and there are probably people and minds outside these rooms who will help contribute in doing that. So we're really excited to be part of these communities and these movements that are becoming part of the norm of many industries, including healthcare. So I function as a corporate strategist within American Heart Association, where I've had the wonderful opportunity to work on what we call as emerging trends and building strategic partnerships. So these are arenas where we cross-functionally look at where American Heart Association is going to participate 5, 10, 15 years from now. So sort of look at it like the hockey puck that's going to land in the future, and part of our job is to make sure that we are headed in the right direction. And it's quite exciting to actually work with a very elite group of folks, both within the institution itself as well as from several volunteers that voluntarily give their time and their knowledge to the American Heart Association. Before I get down into what we do, I want to highlight a few things about the American Heart Association. So for a little over 90 years, the American Heart Association has been investing a little over, I would say, about $3.7 billion in funding what we think is cutting-edge science. And it has also helped launch the careers of many scientists, clinicians, and researchers, leading to about 13 Nobel Prizes that have come out from some of the work that has been funded by the American Heart Association. So it's, as an organization, we take pride in saying that we have about a little over 33,000 academic professionals, researchers, and clinicians within our community, as well as we bask in the generosity of a little over 33 million volunteers and donors who willingly contribute to our success from a grassroots levels point of view. At the heart of the institution, we are a research organization with several of our sister organizations, including the National Institutes for Health as well as NHLBI. There's a lot of advancement that's happening within patient care, as well as finding breakthroughs that are happening pretty much every day, and we love being part of this mission. A few years ago, actually exactly 6 years ago, Nancy Brown, our CEO, made a goal that we call a strategic health impact goal. For many of us, we see it as our path to 2020, but essentially what it says is, we've committed as an organization and as an institution to actually help improve the cardiovascular health of all Americans by 20%, and also help reduce the deaths caused by all cardiovascular and stroke diseases by 20%. So this is the mission that we've committed ourselves to. We still have 3 years ahead of us, and we're pretty confident that we're going to hit on at least the high notes of it. As Gary was talking about his conversations about and experiences around brain, we do see an epidemic within the heart, cardiovascular, and stroke diseases. So many of you know that heart disease is the #1 killer in this country. About 85 million, 82 million, I think, based on last year's information. People suffer from cardiovascular disease. 1 in 3 Americans suffer from it. There's, of course, an epidemic of obesity and related issues that are popping up, and the cost that is being invested in getting treatments is going through the roof. So we definitely see that as an area for, again, accelerating the area of science that can help improve not only treatment but cures tied to various conditions within cardiovascular diseases. I'm going to quickly walk through. I don't think we want to spend too much time on why people, what they love to do. I think we have published several papers. We call it Life Simple 7. So there are 7 things that you do, and you do it well, which involves exercise, food, controlling your blood sugar, weight. You're going to extend your life, and when you go, you kind of go fast. So that's actually the ideal way to live your life. We do think that from a patient advocacy group, we see ourselves as a group that represents patients. I think that's the ultimate ideal position we want to play with, but the current realities of the healthcare system doesn't help that. So the question then becomes is, what is it that the American Heart Association is doing about changing the paradigm and changing the game within which healthcare can be improved from a patient point of view as well as from a clinical science research point of view. So I think this crowd is pretty knowledgeable about some of the new aspects of technology that are coming in. We from the American Heart Association definitely see a huge value in the power of technology, the power of big data, and how that data can be leveraged to drive science. There are several statistics out there. There are 7.5 billion mobile phones out there. The latest statistics that we gathered are by year 2017, 170 million individuals or people actually will have access to some sort of a healthcare-driven application or a biosensor device sitting within their arm's length. You also see about 56 million people already today leveraging a lot of the healthcare technology, especially some of the ones that you see most commonly available. So these are some of the new LifeCore ECG monitors that are now available on iPhones. You can actually do an ECG on your iPhone itself fairly easily to the glucose monitors that connect and several other consumer-grade tracking sensor devices that are already out there. So a big explosion in, again, a paradigm shift in what we see as biosensor-related data that's becoming more and more prevalent. And I think I have a few slides that I'd like to highlight why we think the power of technology is going to help accelerate science. This is an article that I think for those of you who want to see what the future is like, this rise of what we call the empowered patient, I think that's becoming the norm. I think this is a fantastic article written by Nicholas. For those of you who are interested, do look at it, but it explains the fundamental shift in a patient who's now becoming more and more interested in not only sharing and getting more information, but also being an active participant in their treatment mechanisms that are being applied to either themselves or to their loved ones. So you see a clear shift in what we are calling as a paradigm shift. I think from our point of view, we clearly see the future in what we are calling the connected heart health model. Fundamentally, how do you change a relationship between a clinician to a researcher who's actually doing the research itself? The research resulting in what we think are scientific guidelines, which are then sort of taken to market when ordinary people like you and me go see our physicians. So this notion that you have to fundamentally change the relationship between patient and their physicians actually is actually one of the key goals of what we see as a huge value add that is primarily going to be driven through technology and data. So you see many notions of examples. I think several of us who were here yesterday, you saw Michael J. Fox Foundation talk about it. This whole notion of e-visits, teleconference, but AHA ourselves, we're investing big into creating what we think are technology integrated platforms that will help enable this connected heart health mechanism. The other interest as a research-driven organization is how do you modernize care delivery, right? So this clinical practice shift between a intuition-based decisions that are being made sometimes to now a data-driven approach. I think that's again a deep passion that we believe in our mission. So we do see ourselves in that community direction that I think the healthcare is moving towards, and we are definitely looking to be part of the movement there. These are some statistics that I think as we have gone through the journey, and I've been with the American Heart Association for a few years now, it's quite fascinating to see these shifts, and this is the latest shift that we saw come in. This is coming from a report that I think PwC ended up, PricewaterhouseCoopers ended up publishing, but you clearly see that 86% of the clinicians now do believe that the power of the mobile healthcare applications are going to be relevant to their engagement with patients. So you see, and this is a big shift compared to 5 years ago. What's even more fascinating to at least some of us within the AHA is what you see on the right-hand side, where more and more clinicians are becoming comfortable in leveraging and using the data that is generated by these mobile health apps, these biosensor devices, and they're actually more comfortable with 3 areas, which actually surprised us even, which was ear infections, monitoring vital statistics, as well as some of the glucose and some areas around that. So more and more the community is becoming comfortable leveraging clinical data, self-reported patient data being used for making clinical decisions. So that is a great big shift. And I think, again, it again shows the trend of where the direction is going. This is another one of those aspects that actually shouldn't come as a big surprise, but I think is always useful to keep in front of us as we make a lot of decisions within healthcare as organizations and institutions, as well as individuals. So you clearly see that by 2016, by 2017, over 111 million wearables are going to be out there. You also see that the number of staggering numbers that you see that are now adopting and using biosensor-based devices. I think there's a latest prediction which says 1/3 of the US population is going to have access to some sort of a biosensor wearable device by 2019. Now, from our point of view, we see a clear distinction. So there's this FDA-approved wearable biosensor devices that are going to come out in the next 18 to 36 months. So just like doctors prescribe you medication today, they're going to start prescribing biosensor-based devices. So I think you saw some examples that Gary showed on the skin-based, and there's a lot of innovation going on in that space. And then the other explosion is this consumer-grade biosensor wearable devices that is, again, exploding all the time. So what that gives us as the AHA is this explosion of what we call self-reported patient data, which now has to be made available to the research community so that they can do what they do best. We at the AHA, we have talked about 33,000 researchers. They primarily fit basic science, clinical science, and population sciences as expertise, but more and more we see shifted movements towards wanting this kind of data that can augment the EMR, EHR data that's already prevalently available out there. There are several data registries, clinical data registries, well-known open data sources. I think there was Taha who was here yesterday from the FDA. So there's lots of public data assets already available that can be augmented with these kind of wearable devices. There's an interesting slide I found recently, which I thought was nice enough to be showcased here. So this is the movement, again, from the healthcare app perspective, right? So you clearly see that the movement is within the fitness wellness space today, but the other opportunities that you see clearly within the healthcare space of how you tie EMRs and EHRs and how you start doing diagnosis is really key. So again, these are just some statistics that we saw as these guiding pointers within what we see as emerging areas for focus within the American Heart. I think for me, the most important was the one on the right side, which clearly says that more and more people are wanting to be more informed, and that information is really key, and the way in which they digest it needs to be simple, yet it's really relevant and personalized from their mechanism. So the question then becomes so yes, we see the explosion. So what does the AHA see as the future of joining what we think is our research roots, which is where the clinical perspective comes in, as well as the patient perspective, which is actually really important. So we talk about this notion of what we call patient engagement and making it available for research. And over the last several days, I've spent a lot of my time as well as listening to the talks here. You hear about security and consent management. So I think when we look at that, and from a technology point of view, the FedRAMP capabilities and compliances, the ISO 27001, the FSMA moderate, these are areas that are expected, and I think the Amazon services do help provide some of those, to make some of the solutions that I've hinted towards, be HIPAA compliant per se. When we see the power of IoT, to me, that represents the point of convergence, because when there's an explosion of either FDA-approved devices, biosensor devices, or a consumer-grade devices, there's always going to be an explosion of all sorts of new inventions that are going to keep coming out. But you have to find a point of convergence, and I think that's where I see the power of the IoT platform. Again, there are some of us who believe that the point of convergence happen at two levels. There's a software platform level where IoT comes in, And then there's the actual hard, manufacturer's chips, and there are about 2 or 3 names that I will not take the names, but who use the Dyna-ANT and some of the other architectures that actually manufacture these sensors that actually track the movements and the oscilloscopes and some of the other areas. So definitely a point of convergence and the power of IoT that helps act as a funnel to collect all of this data, and then behind the scenes you can park it in data lakes like S3, mash it with EMR, EHR data that's already out there, maybe generate new data, some of the areas that I think Gary mentioned as well. We see a huge value in the elastic MapReduce technology sets that Amazon's come up with, because you can really deploy new techniques like Spark and Presto, and build data models that are very flexible, like the Hive. You can do many things by putting that portion of the work and really start accelerating how that data gets used and how it gets consumed, as well as how it gets sliced and diced. So basically, deploy the power of machine learning to actually help make good decisions better. So, and that's drive the hypothesis that these researchers have, drive the statistical analysis. Instead of using, there are great tools out there, but how do you kind of put it on steroids and move it even further? And we see that as a big notion of what happens when you start moving into this realm of using technology for what is mission driven. So I think these are just, again, aspects for, how do you transform care and research? For us, it's the power of big data. It's the power of bringing data sets together, making them available, discoverable, accessible, making them, I think for those, it would be an understatement to say that some of the data quality management issues and harmonization issues and normalization issues are really big when you start moving from EMR data to clinical data registries to longitudinal data that gets captured through some federally funded cohort, and then this explosion of all sorts of biosensor data coming in. So there are some real complexities ahead, but I think technology is definitely keeping up with the pace, and some of the policies and regulatory aspects need to reflect that. This is probably my last slide, and I should probably say this, that for us, everything is about our mission. So life is why is one of our taglines. When we see technology, down the halls, walking here in the sessions at Amazon, these are technologies that help save lives. So these are life-saving technologies that are really essential to our mission, as well as to the people that we've committed ourselves to, as well as the research community in large. So having said that, thank you. Yeah.
So we'll have a few minutes for questions and answers. So any questions, raise your hand and speak out loud.
Thank you. You started your presentation citing some American Heart Association figures and goals and so forth. From that, can we assume that your presentation and projections and thoughts were concerned more about the United States? And if so, yes or no? But if so, how much of this do you think will, let's say, progress to countries such as China or Peru or Nigeria or other places?
So I think to the first part of your question, yes. So the numbers and the figures that were built were primarily aimed at the U.S. domestic population. What's been interesting to us is actually as we've progressed, international expansion of some of those goals is coming in. In fact, we do, as the American Heart, we are now in 7 international countries, even though we're American Heart Association. We already see a lot of excitement coming in, especially from the Asian countries. China definitely leading the pack there. There's Latin America, Brazil, and some other areas. Europe, of course, is quite mature in how they pursue similar interests, and I think we do have across collaborative efforts. But these are quickly becoming what we see as global efforts. because globally we do see heart disease is still the #1 killer. So we see the impacts of this far-reaching than just the domestic U.S. population. So.
In your healthy aging study, will you be able to account for the tendency for people to keep upgrading their phones with maybe different sensors and more sensitive sensors? How will you normalize the data?
That's a great question. If we have enough resources, we can keep updating the app as people upgrade their phones. Obviously, operating systems progress, so there's going to be a continual investment in tracking with that. The more important question, because that's just a question of having enough programmers and enough money. The more important scientific question, I think, is how do you normalize across lots of different devices, as well as through time as sensors become more sensitive, or perhaps even less sensitive as we discard them and make them cheaper. And so I didn't show any of this analytics, but the type of analytics that we're using are insensitive or designed to be insensitive to different amplitudes and different response systems. So I showed you 2 different graphs where we measured the randomness of the data within that. And actually, it turns out that it doesn't matter how sensitive your accelerometer is in your phone, you still get the same amount of randomness from somebody's behavior. So that's one of the important points, is not picking metrics that are a function of a particular device. And the way you do that is you stratify your data according to different devices, and you train on one set of devices and test on another, and you select your features to be ones that are insensitive to these differences. So it's a really important point. And then you have to do that going through time as well. And we often call that model drift in clinical parlance or clinical informatics, but it is a really important point.
Hi, this is Morta, the AHA. Looking at your models, you're seeing more of people who are using the wearables and filling out apps that are on the healthy side. Do you worry about skewing data because more data comes from healthy individuals than comes from the ill or chronic disease patients?
Yeah, thank you for this question. I think we call it the worried well, right? It's the people who use the wearables today are the ones who are already concerned about health, and chances are they lead a much healthier lifestyle than the rest. In fact, as part of the paper, which I should have, in retrospect, should have put up a link on it, I think less than 4% of the individuals fit that worried well category when we published the paper 2 years ago. But you clearly see the need for the larger population to be more responsive in continuously using some of these mechanisms. Because I don't know if you guys know, but the average Fitbit drop-off rate happens right around 3 months. So people use it and then boom, they just stop using it. And that's, that is a real challenge when you start doing statistical analysis based on data that comes from those kind of sources. But it's a very fair point.
Can I make a comment on that?
Yeah,
as well?
please. Yeah.
I think there's also the opportunity to have the opposite effect as well. So if you look at the way that poorer and more disadvantaged groups of society have leapfrogged through using laptops and other higher-end devices, we've now got an increasing prevalence of lower-income groups using Android phones. And that means that actually we have an increasing ability to access these lower income and disadvantaged groups to actually pull data off them. So I think it's turning around from being the rich worried well to being a system that allows us to penetrate into the poorer groups and the groups that are actually more affected by these type of diseases. I think that's a fair comment.
No, yeah.
Thank you, guys. Actually, if we can hold a question. Thank you.
Thanks.